my presentation, I'll focus on 5 major issues. We'll start with ischemic heart disease, then myocardial disease, cardiomyopathy, endocarditis, and pericardial disease. Just to remind you, the distribution of blood supply to the heart, you see here left coronary artery, anterior descending branch of the left coronary artery, left circumflex artery, and right coronary artery. And various disturbances in the blood supply to the heart may be followed by various structural and clinical changes. Let's start with ischemic heart disease. A general term for diseases of the heart caused by insufficient blood supply to the myocardium. It means that ischemic heart diseases is various pathologies which are within this group. Ischemic heart disease, also known as coronary artery disease, refers to a group of diseases such as acute ischemic heart disease with stable angina, unstable angina, myocardial infarction, and sudden cardiac death. So here you see main pathologies included in acute ischemic heart disease: angina pectoris, stable and unstable, myocardial infarction, and sudden cardiac death. Here you see the coronary artery with pathological changes. We see here a fibrolipid plaque. In cross-section of the plaque, which is stained by Sudan red, we have a plaque with a core of lipid separated from the lumen by the whitish fibrous cap. Here you see the eccentric plaque causing narrowing of the coronary artery, estimated to be over 95% of the lumen. It means that just tiny lumen which is used by blood supply, and therefore we have the symptoms of ischemia in the myocardium. Here you see the microemboli in small intramyocardic vessel. This small artery is occluded by a mass composed of platelets, which looks bluish, red cells, yellowish, and cholesterols, like a clefts. So there are few outcomes of coronary plaque rupture. We may have the occlusive thrombus with chronic total occlusion. Then we may have multi-channeled residual lumen. We may have residual high-grade stenosis, and also healed fissura, no increased in stenosis. Various outcomes of the plaque. Here you see the coronary artery with recanalization. So the lumen of coronary artery has been subdivided into several channels by fibrous strands. Acute myocardial infarction, also known as heart attack, in clinical situation. This is one of the most important forms of ischemic heart disease in industrial patients. Myocardial infarction is caused by decreased myocardial perfusion owing to vasospasm, so spasm of the arteries, thrombosis, embolization, and increased myocardial demand with inadequate myocardial perfusion. For example, for sportsmen during physical exercises, we may have such clinical situation. Atherosclerotic plaque rupture you see here in this picture, and as a result, acute coronary thrombosis, and this could be a trigger for myocardial infarction. And this is a picture of this clinical case. According to the degree of thickness of ventricular wall, degree of the area of the infarction, we may see transmural infarcts, it means all ventricular wall involved, subendocardial infarct, when we have the infarcts within the subendocardial area, subepicardial infarct, and intramural infarcts. Here you see subendocardial myocardial infarction with mural thrombi in the area of the anterior wall of the left ventricle of the heart. We see an irregularly shaped yellowish focus. Also, we see a dark red border. From the endocardium, thrombotic overlays are visible here on the cross section of the heart. Here you see the gross specimen of the heart. Also here you see the lungs, and area shows you the rupture of the infarct. So in this particular case, transmural myocardial infarction followed by rupture of the heart, tamponade of the pericardial cavity results in such hemorrhage. In the apex region, there is an irregularly shaped slit-like opening shown by the arrow, and in the pericardial cavity there are blood clots. So we call it tamponade of the pericardial cavity. We may classify myocardial infarcts according to the duration of necrosis. Acute myocardial infarction develops in the first time during 8 weeks from the beginning of the ischemic necrosis. We may see repeated myocardial infarction, which develops after 8 weeks of acute infarction, and recurring or recidivic myocardial infarction develops during 8 weeks of acute infarction. Here you see the histological picture or microscopical feature of the myocardial infarction. We see 1-day-old infarct showing coagulative necrosis. It is on the top of such picture. We see wavy fibers with elongation and narrowing compared with the adjacent normal fibers in the lower right part of the picture. We see widened spaces between the dead fibers contain edema fluid like here, and scattered neutrophils. Particularly we see more neutrophils between dead and normal myocardial fibers. Here you see the polymorphonuclear leukocytic infiltration in the area of acute myocardial infarction, 3 to 4 days duration. Here you see the dead myocardial cells. you see just the tiny shadows of the nuclei, and here you see intensive leukocytes infiltration between dead fibers. Nearly complete removal of necrotic myocytes by phagocytosis, and this picture is about infarction, approximately myocardial infarction, approximately 7 to 10 days old. Then we see granulation tissue with a rich vascular network and early collagen deposition. And the picture illustrates the infarction approximately 3 weeks old. Collagen is highlighted as blue in this Masson trichrome stain. So bluish staining is a network of early collagen fibers. Here you see well-healed myocardial infarct with replacement of the necrotic fibers by dense collagenous scar. If few residual cardiac muscle cells are present, collagen is highlighted as blue in this Masson trichrome stain. So here the bluish fibers are collagen fibers, and so as a result of myocardial infarction, we see a scar, and we shall call it as post-infarction cardiosclerosis, heart cardiosclerosis. Here you see hemopericardium. This resulted from rupture of an anterolateral myocardial infarction 7 days after the onset of the chest pain. So here you see the pericardial sac filled with chronic ischemic heart disease. Grossly and under microscope, it could be presented with cardiosclerosis. Cardiosclerosis may be local, it means post-infarctional, so after the myocardial infarction, and it could be in the form of diffuse cardiosclerosis as a result of atherosclerotic changes. Myocardial disease. Involvement of the myocardium occurs in 3 major forms of disease, already discussed: ischemic heart disease, hypertensive heart disease, and rheumatic heart disease. In addition, there are 2 other broad groups of myocardial diseases, like myocarditises. It means inflammatory involvement of the myocardium. Cardiomyopathy, which means non-inflammatory myocardial involvement with often unknown primary or known, it means secondary disease, the etiology of cardiomyopathy. Let's discuss myocarditis. Inflammation of the heart muscle is called myocarditis. It is a rather common form of the heart disease that can occur at any age of the patient. Its exact incidence is difficult to ascertain, as the histological examination has been largely confined to autopsy material. Reports from different studies have estimated the incidence of myocarditis between 1 to 4% of all autopsies. A number of classifications of myocarditis have been proposed in the past as follows: interstitial and parenchymatous type, depending upon whether the inflammation is confined to interstitial tissue or the parenchyma. Specific and non-specific type, depending upon whether the inflammation is granulomatous or non-specific type. Acute, subacute, and chronic type, depending upon the duration of inflammatory response. According to this classification, myocarditis is divided into 4 main etiological types described below. How it looks like when we study heart with the naked eye. Grossly, the myocardium is pale and flabby with dilatation of the chambers. There may be focal or patchy areas of dystrophy and necrosis. Here we see such example of gross picture of the heart, the cross section, and we see the dilatation of the chambers and some patchy areas of necrosis. Histologically and immunologically, we can various changes. We see various features, immunohistochemical features. We see areas of dystrophy and necrosis, and radioactive in situ hybridization reveals PVB19 nucleic acid in endothelial cells of an arteriole in patients with chronic myocarditis, whereas enterovirus ribonucleic acid is detected in several myocytes. Histologically, there are some features in case of acute myocarditis. Initially, there is edema and infiltration of the interstitial tissue by neutrophils and lymphocytes. Here you see such areas of infiltration. Later, there is necrosis of individual myocardial fibers, and the infiltrate consists of lymphocytes and macrophages. Sometimes we see such form of the myocardial inflammation like suppurative myocarditis. Pyogenic bacteria like Staphylococcus or Streptococcus, which cause septicemia and pyemia, may produce suppurative myocarditis, not often. As has already pointed out, active bacterial endocarditis may sometimes cause bacterial myocarditis. Grossly, there are either abscesses in myocardium or there is diffuse myocardial involvement. Under microscope, exudate mainly consists of neutrophils admixed with lymphocytes, plasma cells, and macrophages. There may be foods of myocardial degeneration and necrosis with areas of healing fibrosis. Here we see suppurative myocarditis. Look, there are some foci of suppurative inflammation, like small abscesses within the myocardial tissue. Now we go to idiopathic Fiedler's myocarditis. Idiopathic or Fiedler's myocarditis is an isolated myocarditis unaccompanied by inflammatory changes in the endocardium or pericardium and occurs without the usual apparent cases. The condition is rapidly progressive and causes sudden severe cardiac failure or sudden death of a patient. In that case, grossly, the heart is soft and flabby. and cardiac chambers are often dilated. Sometimes we see the hypertrophy of the wall. There are yellow-gray focal lesions throughout the myocardium, and also mural thrombi are commonly present. Histologically, two forms of idiopathic myocarditis are described. We see diffuse type and giant cell, so-called idiopathic granulomatous type. So, diffuse type is more common, and giant cell type or idiopathic granulomatous type sometimes also used. Here we see the giant cell type or idiopathic granulomatous type of myocarditis. In case of diffuse type, we see diffuse non-specific inflammatory infiltrate consisting of lymphocyte, plasma cells, macrophages, eosinophils, and few polymorphs in the interstitial tissue without formation of granulomas. Late stage shows healing by fibrosis. Giant cell type or idiopathic granulomatous type is characterized by formation of no caseating granulomas, so it is not like granulomas in case of tuberculosis. Such granulomas consist of macrophages, lymphocytes, plasma cells, and multinucleate giant cells. But please remember, no gaseous necrosis. The giant cells are of foreign body or Langerhans type or of myogenic origin. The granulomas do not show presence of acid-fat bacilli or spirochetes, so there is no connection with tuberculosis or syphilis. Some have suggested the relationship of this condition with sarcoidosis, but sarcoid granulomas are known to occur in the myocardium secondary to generalized sarcoidosis. So, in case of sarcoidosis, we must see other examples of such pathology, for example, in lung. Myocarditis in connective tissue diseases. So, it means in rheumatic diseases. Inflammatory involvement of the myocardium occurs in a number of connective tissue diseases such as rheumatoid arthritis, lupus erythematosus, polyarthritis nodosa, dermatomyositis, and scleroderma. The pathologic changes in the heart muscle are similar to the changes seen in other organs in these conditions and are described in the lectures. Miscellaneous types of myocarditis. Apart from the above form of myocarditis, miscellaneous group consists of myocarditis caused by a variety of agents, both physical and chemical, drugs and metabolic derangements. So here you see few possible causes of such pathology: physical agents, chemical causes, drugs, immunology disturbances, and metabolic derangements. Now we go to cardiomyopathy. So here in this picture, we may compare major pathophysiological forms of idiopathic cardiomyopathies. Idiopathic, it means they are primary and we do not know real cause of such pathology. On the left, you see the normal heart You see how endocardium, pericardium, and myocardium look like in normal situation, in physiological condition. And in case of dilated cardiomyopathy, you see the thickened endocardium, dilated lamina, and sometimes we see the mural thrombosis. In case of hypertrophic cardiomyopathy, look, you see septal hypertrophy, asymmetrical thickened myocardium, and in this case, the lumen is smaller than in normal heart, so we call it like obliterated lamina. And restricted cardiomyopathy, we see a thickened mural endocardium and no real changes in the chambers of the heart. Cardiomyopathy means diseases of the heart muscle, but the term was originally going to restrict its usage to myocardial disease of unknown cause. The World Health Organization definition of cardiomyopathy also excludes heart muscle disease of known etiologies. However, the term cardiomyopathy has been loosely used by various workers for myocardial diseases of known etiology, as well as alcoholic cardiomyopathy, amyloid cardiomyopathy, ischemic cardiomyopathy, etc. This controversy is resolved by classifying all cardiomyopathies into two broad groups. The first one, primary cardiomyopathy, and the second group, secondary cardiomyopathy, so myocardial diseases with quite known underlying cause. Let's start with primary cardiomyopathy. This is a group of myocardial diseases of unknown cause. It is subdivided into the following three pathophysiological categories. Idiopathic dilated or congestive cardiomyopathy, idiopathic hypertrophic cardiomyopathy, idiopathic restrictive or obliterative or infiltrative cardiomyopathy. I have already shown the example and the picture before. Let's start with idiopathic dilated or congestive cardiomyopathy. This type of cardiomyopathy is characterized by gradually progressive cardiac failure along with dilatation of all the four chambers of the heart. The condition occurs more often in adults, and the average survival from the onset to death is less than 5 years. Though the etiology is unknown, a few hypotheses based on association with the following condition have been proposed. The first possible condition is the association of viral myocarditis, especially Coxsackie virus B, with dilated cardiomyopathy due to presence of viral nucleic acids in the myocardium, which was discovered. Association with the toxic damage from the cobalt and chemotherapy with doxorubicin and other anthracyclines is implicated in some cases. This is the second group. And the third, inherited mutation, which may cause the occurrence of such disease in families. Mutations in certain sarcomere proteins such as cardiac troponin T and IB and A myosin and A cardiac actin have been observed. Chronic alcoholism has been found associated with dilated cardiomyopathy. It may be due to thiamine deficiency induced by alcohol and resulting in very heart disease. This is referred to as alcoholic cardiomyopathy and included by some workers as one of the subtypes of secondary cardiomyopathy. However, moderate consumption of alcohol provides some cardioprotein against ischemic heart disease by raising HDL cholesterol. Another form of alcoholic cardiomyopathy is associated with consumption of large quantities of beer drinkers' myocardiosis. Cobalt added to the beer so as to improve the appearance of foam is thought to cause direct toxic injury to the heart in this condition. Peripartum association has been observed in some cases. Poorly nourished women may develop this form of cardiomyopathy within a month before or after delivery. So it has a name as peripartum cardiomyopathy. Few words about morphology. Grossly, we see the heart, which is enlarged, increased in weight up to 1,000 grams. The most characteristic features is a prominent dilatation of all the four chambers, giving the heart typical globular appearance. Thickening of the ventricular walls, even if present, is masked by the ventricular dilatation. The endocardium is thickened and bural thrombi are often found in the ventricles and atria. The cardiac valves are usually normal. Microscopically, the endocardial biopsies or autopsy examination of the heart reveal non-specific and variable changes. There may be hypertrophy of some myocardial fibers and atrophy of other fibers. Sometimes degenerative changes and small areas of interstitial fibrosis are found with focal mononuclear inflammatory cell infiltrate. Idiopathic hypertrophic cardiomyopathy. This form of cardiomyopathy is known by various synonyms like asymmetrical hypertrophy, hypertrophic subaortic stenosis, and Tears disease. The disease occurs more frequently between the age of 25 and 50 years. It is often asymptomatic but becomes symptomatic due to heavy physical activity causing dyspnea, angina, congestive heart failure, and even sudden death of a patient. Though idiopathic, following factors have been implicated, so they are possible causes of such changes. Autosomal dominant inheritance of the disease is available in about half of the cases, suggesting genetic fatigue in its causation. Inherited mutation in genes encoding for sarcomere proteins have been reported in much larger numbers of cases of hypertrophic cardiomyopathy than those of dilated cardiomyopathy. Particularly implicated are the mutation in heavy and light chains of cardiac B myosin, troponin 1 and troponin T. The condition may result from myocardial ischemia resulting in fibrosis of the intramyocardial arteries and compensatory hypertrophy. Other contributory factors are increased circulatory level of catecholamines. Myocardial ischemia is a result of thickened vasculature of the myocardium and abnormally increased fibrous tissue in the myocardium due to hypertrophy. What we see grossly, the characteristic features are cardiac enlargement, increase in weight, normal small ventricular cavities, and myocardial hypertrophy. The hypertrophy of the myocardium is typically asymmetrical and affects the interventricular septum more than the free walls of the ventricles. The asymmetric septal hypertrophy may be confined to the apical region of the septum, non-obstructive type, or may extend up to the level of mitral valve, causing obstruction to left ventricular outflow in the form of subaortic stenosis, and in that case we call it obstructive type. The designation of rhabdomyoma of the septum was applied to this form of cardiomyopathy in some old scientific literature. Under microscope, we see myocardial cell disorganization in ventricular septum. The bundles of myocardial fibers are irregularly and haphazardly arranged than the usual parallel pattern and are separated by bands of interstitial fibrous tissue. The individual muscle cells show hypertrophy and large prominent nuclei. Idiopathic restrictive or obliterative or infiltrative cardiomyopathy, it's another kind of disease. This form is characterized by restriction in ventricular filling due to reduction in the volume of the heart chambers. The common feature in this heterogeneous group of conditions producing restrictive cardiomyopathy is abnormal diastolic function. Restrictive cardiomyopathy includes the following entities: cardiac amyloidosis, endocardium fibroelastosis, endomyocardial fibrosis, Leffler endocarditis or fibroblastic parietal endocarditis with peripheral blood eosinophilia, and also other forms of restrictive cardiomyopathies included in this. Let's start with cardiac amyloidosis. You know this pathology. Amyloidosis of the heart may occur in any form of systemic amyloidosis, or sometimes we see this kind of pathology as isolated organ amyloidosis in amyloid of aging and result in subendocardial deposits of amyloid. The next one is endocardial fibroelastosis. This is an unusual and uncommon form of the heart disease occurring predominantly in infants and children under 2 years of age, and less often seen in adults. The infantile form is clinically characterized by sudden breathlessness, cyanosis, cardiac failure, and death, whereas the symptoms in the adult form last for longer duration. The etiology of the condition remains obscure. However, a number of theories have been proposed. For example, the infantile form is believed to be congenital in origin occurring due to the effect of intrauterine endocardial anoxia. The adult form may also be induced by anoxia-causing lesions such as anomalous coronary arteries, metabolic derangements influencing myocardial function, and other causes. It may occur due to hemodynamic pressure overload such as in congenital septal defects and coarctation of the aorta. It may be an expression of genetic disorders as noticed in twins, triplets, and siblings. Association of endocardial fibrinostosis with various congenital malformations in the heart or elsewhere further supports the genetic theory. Some pathologists consider this disease as a form of connective tissue disorder. Certain factors causing myocardial injury may initiate the endocardial disease, such as thiamine deficiency in case of beriberi heart disease, or from preceding idiopathic myocarditis. Lymphatic obstruction of the heart has been suggested by some scientists as a causative mechanism of such pathology. Morphological features include gross and microscopical patterns. Grossly, the characteristic features is the diffuse or patchy, rigid, whitish thickening of the mural endocardium. Left ventricle is predominantly involved in this pathology, but less often the left atrium, right ventricle, and right atrium involved. Quite often in the valves, especially of the left heart, are affected also. Some cases contain mural thrombi. Enlargement of the heart is present and is mainly due to left ventricular hypertrophy, but the volume of the chamber is decreased. Under microscope, the typical finding is the proliferation of the collagen and elastic tissue. That is why we call it fibroelastosis, comprising the thickened endocardium. The fibroelastosis generally does not extend into subjacent myocardium. The lesion is devoid of inflammatory, so no inflammation. Other form is the endomyocardial fibrosis. This form of restrictive cardiomyopathy is a tropical condition prevalent in Africa, especially in Uganda and Nigeria, but some cases occur in South India, Sri Lanka, Malaysia, and tropical South America. It is seen in children and young adults. The clinical manifestations consist of congestive heart failure of unknown cause, just as in adult variety of endocardial fibrinostosis. The etiology of conditions remains obscure, but the geographic distribution suggests the role of certain factors like malnutrition, viral infections, and heavy consumption of banana, rich in serotonin. Grossly, endomyocardial fibrosis is characterized by fibrous scarring of the ventricular endocardium that extend to involve the inner third of myocardium. The atrioventricular valve leaflets are often affected, but the semilunar valve are uninvolved. Mural thrombi may be present in this case. The heart may be normal-sized or hypertrophied, but the volume of the affected chambers is diminished due to fibrous scarring. Under microscope, the endocardium and parts of inner third of myocardium show destruction of normal tissue and replacement by fibrous tissue. The condition differs from endocardial fibrinostosis in having mononuclear inflammatory cell infiltrate and lacking in elastic tissue. The superficial layer may show dense, hyalinized connective tissue and even calcification of the tissue. Loeffler's endocarditis, also known by the more descriptive term fibroblastic parietal endocarditis with peripheral blood eosinophilia. The condition is considered by some as a variant of the entity described above, like endomyocardial fibrosis. However, it differs from the latter in the following respects. There is generally a peripheral blood eosinophilic leukocytosis. The inflammatory infiltrate of the endocardium and in the part of affected myocardium chiefly consists of eosinophils, and the condition has prognosis. Other forms of restrictive cardiomyopathy, you must also remember them. Restrictive cardiomyopathy may result from various diseases like hemochromatosis due to iron overload from multiple transfusions, for example, or in case of hemoglobinopathies. Myocardial sarcoidosis may result in cardiomyopathy. Carcinoid syndrome, scleroderma, neoplastic infiltration in the heart may also cause the symptoms of restrictive cardiomyopathy. Now we go to secondary cardiomyopathy. This is a group of myocardial diseases of known etiology, so we know the causes of such cardiomyopathies. Or we may see some clinical associations. This, however, excludes well-defined entities such as ischemic, hypertensive, valvular, pericardial, congenital, and inflammatory involvements of the heart. The main entities included in this group are described elsewhere in other parts of my lecture. Let's list such secondary cardiomyopathies like nutritional disorders. An example we have already mentioned, alcoholism, toxic chemicals like cobalt, arsenic, lithium, and other toxins may cause such cardiomyopathy. Various drugs, metabolic disorders, neuromuscular diseases, various infiltration due to leukemia and carcinoma, connective tissue diseases may cause, all of them may cause secondary cardiomyopathies. Endocardium involved. Inflammatory involvement of the endocardial layer of the heart is called endocarditis. Though in common usage, if not specified, endocarditis would mean inflammation of the valvular endocardium. Several scientists designate endocarditis on the basis of anatomic area of the involved endocardium, and therefore they mention valvular endocarditis, mural, it means the inner lining of the cardiac chambers, chordal for the endocardium of the chordae tendineum, trabecular for the endocardium of trabecular cornea, and papillary for the endocardium covering the papillary muscles. So various areas of endocardium involvement. Endocarditis can be broadly grouped into non-infection and infection endocarditis. Most types of endocarditis are characterized by the presence of so-called vegetations of verruca, which have distinct features. Atypical verrucous Liebman-Sachs endocarditis. Liebman and Sachs, two American physicians, described a form of endocarditis in 1924 that is characterized by sterile endocardial vegetation, which are distinguishable from the vegetation of the endocarditis in case of rheumatic heart disease and bacterial endocarditis in case of sepsis. Etiopathogenesis. Atypical varicose endocarditis is one of the manifestations of so-called collagen diseases. Characteristic lesions of Liebman-Sachs endocarditis are seen in 50% or half of cases of acute systemic lupus erythematosus. Other diseases associated with this form of endocarditis are systemic sclerosis, thrombotic thrombocytopenic purpura, and other collagen diseases. Grossly, characteristic vegetation occur most frequently on the mitral and tricuspid valves. The vegetations of atypical varicose endocarditis are small. They are from 1 to 4 millimeters in diameter. They are granular, multiple, and tend to occur on both surfaces of affected valves. In the valve pockets and on the adjoining ventricular and atrial endocardium, we also see some changes. So such vegetations are sterile unless superimposed by bacterial endocarditis. Unlike vegetation in case of rheumatic heart disease, the healed vegetations of Liebman-Sachs endocarditis do not produce any significant valvular deformity, so no deformations. Frequently, fibrinous or serofibrinous pericarditis with pericardial effusions is associated. Microscopically, the verruca of Liebman-Sachs endocarditis are composed of fibrinoid material with superimposed fibrin and platelet thrombium. The endocardium underlying the verruca shows characteristic histological changes, which include fibrinoid necrosis, proliferation of capillaries, infiltration by histiocytes, plasma cells, lymphocytes, neutrophils, and hematoxylin bodies, which are counterparts of the lupus erythematosus cells of the blood. So we see in some inflammatory changes within the interstitial connective tissue of the myocardium, but Schopf bodies are never found in the endocardium or cardium in this case. Non-bacterial thrombotic endocarditis. It has other names: cachectic, merantic, terminal endocarditis, or endocarditis simplex, is an involvement of the heart valves by sterile thrombotic vegetation. Etiopathogenesis. It is not quite clear. Vegetations are found at autopsy up to 5% of all cases of death. The following diseases and conditions are frequently associated with such pathology. In patients having hypercoagulability state from various causes, like advanced cancer, for example, in case of adenocarcinomas, Also, chronic tuberculosis, renal failure, and chronic sepsis may be accompanied by such endocarditis. Also, occurrence of such lesions can be seen in young and well-nourished patients, but also in case of allergy, vitamin C deficiency, deep vein thrombosis, and endocardial trauma, for example, due to a catheter in pulmonary artery, and hemodynamic trauma to the heart valves. Grossly, the verruca located on cardiac valves, mainly we see such pathologies in mitral and less often in aortic and tricuspid valve. These verrucae are usually small, up to 5 mm in diameter. They could be single or multiple, brownish, yellowish brownish, and occur along the line of closure of the leaflets, but are more friable than the vegetation of rheumatic heart disease. Organized and healed vegetation appears as fibrous nodules. Normal age-related appearance of the tag-like appendages at the margin of the valve cusp, known as lumpus excrescences, is an example of such healed lesions. Under microscope, this vegetation composed of fibrin along with red blood cells, white blood cells, and platelets. Vegetations are sterile, do not cause tissue destruction, and therefore we can't see any damage to collagen fibers, but we see that they are swollen. Fibrinoid changes and capillary proliferation also seen, but no inflammatory reaction. Embolic phenomenon is seen in many cases of such endocarditis and results in infarcts in the brain, lungs, spleen, and kidneys. The plant vegetation in such endocarditis may produce them later when some bacterial infection added. This pathology may be changed by bacterial type endocarditis. So now we go to infective or bacterial endocarditis. Infective or bacterial endocarditis is serious infection of the valvular and mural endocardium caused by different forms of microorganism and is characterized by typical infected and friable vegetations. A few specific forms of infective endocarditis are named by the microbial etiological agent causing them. For example, tubercle bacilli, fungi, and other pathologies. Depending upon the severity of infection, we may see either acute bacterial endocarditis or subacute bacterial endocarditis. Other words or synonym we call such endocarditis, endocarditis. Let's start with acute bacterial endocarditis. This disease is fulminant and destructive acute infection of the endocardium caused by highly virulent bacteria in a previously normal heart and almost invariably runs a rapid fatal course in a period of 2 6 weeks of disease. Subacute bacterial endocarditis or endocarditis lenta, lenta in Latin means slow, is caused by less virulent bacteria in a previously diseased heart and has a gradual downhill course in a period of 6 weeks to a few months and sometimes years. You must know that although classification of bacterial endocarditis has been largely discarded because the clinical course is altered by antibiotic treatment, so quite difficult sometimes differ acute and subacute form of disease. Still, a few important distinguishable features are worth describing. However, features of the vegetations in acute and subacute form are difficult to distinguish. All cases of bacterial endocarditis are caused by infection with microorganism in patients having certain predisposing factor. So, infective agents are important, and predisposing factors also play important role. There are 3 main factors which predispose to development of both forms of bacterial endocarditis. First, conditions initiating transient bacteremia, septicemia or pyemia. Second, underlying heart disease. And the third one, impaired host defenses. About 90% of bacterial endocarditis are caused by streptococci and staphylococci. In the most common causative organism are virulent strains of staphylococci, chiefly Staphylococcus aureus. Others, less common, are pneumococci, gonococci, streptococci, and enterococci. In subacute bacterial endocarditis, the commonest causative organism are streptococci with low virulence, predominantly Streptococcus viridans, which forms part of normal flora of the mouth and pharynx. Other, less common etiological agents include other strains of Streptococci and Staphylococci. For example, Streptococcus bovis, which is normal inhabitant of gastrointestinal tract, Staphylococcus pneumoniae and Staphylococcus epidermidis, which are common in the skin. Gram-negative enteric bacilli like Escherichia coli, Klebsiella, Pseudomonas, and Salmonella, various pneumococci, gonococci, Haemophilus influenza, all of them may cause such endocarditis. Here you see the picture illustrating infective endocarditis. Grossly, we see the mitral valve, then we see the left ventricle, and in the mitral valve we see the congestion of the vessel, the injury of endocardium, and we see the vegetation in case of bacterial endocarditis on the surface. The vegetation include necrotic debris, bacterial colonies, outer layer as a carb, rich with polymorphonuclear neutrophils. And here under microscope we see the endothelial damage, the fibrous fibrinous material. Also, we see the chronic inflammatory cells, edema within the valvular stroma, and newly formed capillaries. So, this section of the mitral valve shows the inflammation with the prominence of neutrophils, and also the injury of the endothelial cells covered by the vegetations. Conditions initiating transient bacteremia, septicemia, and pyemia. Bacteria gain entrance to the bloodstream, causing transient and clinically silent bacteremia in a variety of day-to-day procedures, as well as from other sources of infection. Some of the common examples are like periodontal infections, such as trauma from vigorous brushing of the teeth, had during tooth extraction and other dental procedures, infections of the genitourinary tract, such as catheterization, cystoscopy, obstetrical procedures, including normal delivery and abortions, infections of gastrointestinal and biliary tract, surgery of the bowel, biliary tract, and genitourinary tract, skin infections such as boils, carbuncles, abscesses, upper and lower respiratory tract infections, including bacterial pneumonias, intravenous drug abuse, cardiac catheterization, and cardiac surgery for implantation of prosthetic valves. Here you see the picture of infective endocarditis. We see location of vegetations on the valves of the left heart. The vegetations are shown on the mitral valve as viewed from the left atrium, and we see the destruction, the injury of valve leaflets. Subacute bacterial endocarditis occurs much more frequently in previously diseased heart valves, whereas the acute bacterial endocarditis is commonly seen in previously normal heart. Amongst the commonly associated and underlying heart diseases are chronic rheumatic valvular disease. It may be seen in about half of all cases, congenital heart disease in about 20% of cases, this including various pathology like coarctation of aorta, pulmonary stenosis, some aortic stenosis, and others. Other causes like syphilis, atherosclerosis, prosthetic heart valves, and others. The impaired host differences may cause the outcome of the disease. All conditions in which there is depression of specific immunity, deficiency of complement, and defective phagocytic function, all them predisposed to bacterial endocarditis. Following are some of the examples of such conditions. For example, lymphomas, which result in impaired specific immunity. So patients with lymphomas may have later bacterial endocarditis. Various leukemias, the same situation. Cytotoxic therapy for various forms of cancers and transplant patients. Deficient functions of neutrophils and macrophages. Bacteria causing bacterial endocarditis on entering the bloodstream from any of the above-mentioned routes are implanted on the cardiac valves or mural endocardium because they have surface adhesions molecules which mediate their adherence to injured endocardium. There are several predisposing conditions which explain the development of bacterial implants on the valves, like circulating bacteria are lodged much more frequently on previously damaged valves from disease, for example, in case of rheumatic heart disease, congenital heart disease, prosthetic valves, they are commonly seen compared with healthy valves. Conditions producing hemodynamic stress on the valves are liable to cause damage to the endothelium, favoring the formation of platelet fibrin thrombi, which get infected from circulating bacteria, and that may result in bacterial endocarditis. Another alternative hypothesis is the occurrence of non-bacterial thrombotic endocarditis from prolonged stress, which is followed by bacterial contamination. The characteristic pathologic feature in both acute and subacute bacterial endocarditis is the presence of typical vegetations of verrucae in Latin on the valve cusps of the leaflets, and less often on mural endocardium, which are quite distinct for other types. Grossly, the lesions are found commonly on the valves of the left heart, most frequently on the mitral, followed in descending frequency by the aortic, simultaneous involvement of both mitral and aortic valves, and quite rarely on the valves of the right heart. The vegetation and subacute bacterial endocarditis are more often seen on previously diseased valve, whereas the vegetations of acute bacterial endocarditis are often found on previously normal valves. Like in rheumatic heart disease, the vegetations are often located on the atrial surface of atrioventricular valves and ventricular surface of the semilunar valves. They begin from the contact areas of the valve and may extend along the surface of the valve and on the adjacent endocardium. Here you see the picture of mitral valve from atrial surface, and we see the vegetation and bacterial endocarditis. The similar vegetation could be seen in aortic valve. We see such picture from ventricular surface. The vegetation of bacterial endocarditis vary in size from a few millimeters to several centimeters. They are green, grayish, greenish, irregular. They are single or multiple, typically friable. They may appear flat, filiform, fungating, or polypoid pattern. The vegetation in acute bacterial endocarditis tend to be bulkier and globular than those in subacute kind of disease, and are located more often in previously normal valves. They may cause ulceration or perforation of the underlying valve leaflets, or may produce myocardial abscesses. Please remember, this is the main difference in morphology from endocarditis in case of rheumatic heart disease. In bacterial endocarditis, we see ulceration or perforation of the underlying or we see the underlying valve leaflet changes. So therefore, at dissection, we see the ulceration or sometimes perforation of the valve leaflets, and this may help to make right diagnosis of bacterial endocarditis. Microscopically, the vegetation of the bacterial endocarditis consists of few zones. I have already shown in the picture that outer layer of the cup consists of eosinophilic material, which include fibrin and platelets. Then we see basophilic zone with colonies of bacteria, and deeper zone, non-specific inflammatory reaction, and sometimes the evidence of repair. Most cases of bacterial endocarditis presented with a fever in patients. The acute form of bacterial endocarditis characterized by high-grade fever, chills, weakness, malaise, while the subacute form of the disease has non-specific manifestation, like slight fever, fatigue, loss of weight, and flu-like symptoms. In early stage, the lesions are confined to the heart, whilst subsequent progression of the disease leads to the involvement of extracardiac organs. In general, severe complications develop early in acute bacterial endocarditis, then in subacute bacterial endocarditis. Complications and sequelae of the bacterial endocarditis are divided into cardiac and extracardial complications. Cardiac complications could be valvular stenosis or insufficiency, perforation, rupture, and aneurysm of valve leaflets, abscesses in the valve ring, myocardial abscesses, suppurative pericarditis, cardiac failure from one of the or more of the foregoing complications. The extracardiac complications also may be present. Since the vegetation in bacterial endocarditis are typically friable, they tend to get dislodged due to rapid stream of blood and give rise to embolism, which is responsible for very common and serious extracardial complications. For example, we see embolia originating from the left side of the heart, then entering the systemic circulation and affect organs like spleen, kidneys, brain, and we may have the infarcts, abscesses, and also aneurysm formations. Emboli rising from the right side of the heart enter the pulmonary circulation and produce pulmonary abscesses. Also, petechial hemorrhages may be seen in the skin, conjunctiva due to either emboli or toxic damage to the capillaries. In subacute bacterial endocarditis, there are painful tender nodules on the fingertips of hands and feet called Osler's nodes, while in acute bacterial endocarditis there is appearance of painless, non-tender subcutaneous maculopapular lesion. Extracardiac complications may also include not only described above, but also focal necrotizing glomerulonephritis, which is seen most common in subacute bacterial endocarditis than in acute bacterial endocarditis. So sometimes we see diffuse glomerulonephritis, and this may be a result from circulating immune complexes with hypersensitivity phenomenon in clinical picture of the disease. Treatment of bacterial endocarditis with antibiotics and adequate dosage kills bacteria, but complications as sequelae of healed endocardial lesions may occur even after the successful therapy. The causes of death and are cardiac failure, persistent infection, embolism to vital organs. Sometimes renal failure may happen, or rupture of aneurysm in cerebral arteries. So here we see the picture of complications and sequelae of infective endocarditis. Here we see on the left the heart with the valves. We see the abscess of valve ring, aneurysm of valve cusp, myocardial abscesses, suppurative pericarditis, and extracardiac complications within the non-cardiac systemic pathologies like brain infarcts, abscesses, various petechial hemorrhages. In lungs, we may have the abscesses, spleen, kidney, and osseous nodes in subacute painful and painless in acute bacterial endocarditis. Janeway's spots, it has a name in that. Specific types of infective endocarditis, like in case of syphilis, the severe manifestation is aortic valvular incompetence. In case of fungal infection, quite rare, we may have the changing in endocarditis and endocardium due to long-term antibiotic therapy, intravenous drug abuses, and other prosthetic valve replacement. And in that case, quite often we see the fungal infection, and this produces the appearance of endocardium similar to bacterial endocarditis, and we see the vegetations, but they are bulkier in case of fungal endocarditis. Viral endocarditis is seen experimental in pathology. Rickettsial endocarditis is a quite rare case of pathology, but sometimes seen in patients with rickettsia infection in Q. Now we go to pericardial disease. Just a few words about such pathology. Diseases of the pericardium are usually secondary to or associated with other cardiac and systemic diseases, and we recognize two types: pericardial fluid accumulations and pericarditis. Accumulations of fluid in pericardial sac may be blood or watery. According to two times, we see hydropericardium or pericardial effusions and hemopericardium. Accumulation of fluid in pericardial cavity due to non-inflammatory causes is called hydropericardium, pericardial effusion. Normally, the pericardial cavity contains up to 50 millimeters of clear watery fluid, but considerable quantity of fluid, up to 1000 milliliters, can be accommodated in the pericardial cavity without serious effect. But the effect of on cardiac function quite slow. But sudden accumulation of a smaller volume, up to 250 milliliters, may produce deficient diastolic filling of the cardiac chambers. For example, such condition we see in cardiac tamponade. Pericardial effusion is detected by cardiac enlargement in X-ray and but faint speed. There are various types of effusions. Serous effusions, this is a common time occurring in condition in which there is generalized edema, for example, cardiac edema, renal, nutritional, hepatic causes of such edema. The serosal surface is smooth and glistening. Sera-sanguineous effusions, for example, we see such situation in blunt trauma to chest and cardiopulmonary resuscitations. Hairless effusions, we see milky or hairless fluid accumulates in condition causing lymphatic obstruction. Cholesterol infusion, this is a rare type of fluid accumulation characterized by presence of cholesterol crystals such as in mechanism. Hemopericardium is accumulation of pure blood in pericardial sac, and this condition must be distinguished from hemorrhagic pericarditis, in which there is escape of small quantities of blood into pericardial cavity. Massive and sudden bleeding into the sac causes compression of the heart, leading to cardiac tamponade. The causes of hemopericardium are like rupture of the heart through myocardial infarction, a rupture of dissecting aneurysm, bleeding diathesis such as scurry, acute leukemia, thrombocytopenia, trauma following cardiopulmonary resuscitation or by laceration of a coronary artery. Pericarditis is the inflammatory disease. Generally, it is a secondary to other diseases of heart or caused by systemic pathology. Primary or idiopathic pericarditis quite rare. Pericarditis morphologically classified into acute and chronic types, and they have various etiologies. We distinguish serous pericarditis, fibrinous or serofibrinous pericarditis, purulent or fibrino-purulent pericarditis, and hemorrhagic pericarditis. And all types of pericarditis, acute pericarditis, serous type of pericarditis could be caused by various pathology like viral infection, rheumatic fever, rheumatoid arthritis, and other diseases. Under microscope, we see infiltration by neutrophils, lymphocytes, and other fibrinous or serofibrinous pericarditis, uremia, myocardial infarction, rheumatic fever, and other pathologies. And we see shaggy fibrinous exudate, which gives bread and butter appearance. Here, under microscope, we see the fibrino-purulent pericarditis and purulent pericarditis caused by pyogenic bacteria. Under microscope, we see the infiltration of neutrophils And the last one, hemorrhagic pericarditis, in case of neoplastic pathologies, hemorrhagic diathesis, tuberculosis, severe acute infections. Chronic pericarditis, in case of tuberculosis, chronic adhesive pericarditis, chronic constrictive pericarditis, and pericardial plaques. So we see the appearance in heart and pericardium in chronic adhesive and chronic constrictive pericarditis. There are various cases of pericarditis seen in tuberculosis. In case of chronic adhesive pericarditis, the stage of organization and healing of the pericarditis and various pathologies. This is the end of my lecture. You may go back and see when you wish to see again, according to the link of my lecture. Thank you for your attention.